Welcome to IETCM, the emergency medicine channel. So we know we started the endocrine emergency series. In the last two part, we dealt regarding the diabetic emergency. In that we talked regarding the hypoglycemia and then diabetic keto emergency as a part of hyperglycemic emergency. So in hyperglycemic emergency, again one more thing is there. Apart from DKA, we have a state of HHS, means hyperosmolar hyperglycemic state. So in this presentation, we'll see some of the few things. So this is what my outline of presentation. So we'll see the hyperosmolar hyperglycemic state. What is means by HHS? Or the person they will refer like a honk, means hyperosmolar non-ketoic coma, HONK. Okay, there is also one of the terminologies commonly we are using. So in this HHS, we have two major important parts. First one is there is a hyperosmolar and then hyperglycemic state. Hyperosmolar. What is mean by, before that hyperosmolar, what is mean by osmolarity? Osmolarity means there is a amount of solute in the solvent. So here in your blood, solute in the sense that is your electrolytes, proteins, glucose, everything that will comes under the substances, that all substance that will comes under the solute particles. So that is the amount of solutes in solvent in the sense that is fluid. Okay, so this is called the osmolality or osmolarity. So if you are measuring in a human being, means that is a osmolarity. If you are measuring in the water fluid in a separate for some other purpose, means that is called the osmolality, LALITY. Here LARITY, osmolarity. So amount of solid. In what is happening in hyper HHS means there is a hyper osmolarity, means there is a excess amount of your solute level, means solute in the sense there will be excess level of, likewise your glucose molecules or sodium, those are the things will be in an excessive state, that is called the hyperosmolarity. And then second part is a hyperglycemia. We know the level is glucose level will be in a higher state, that is a hyperglycemic state. Okay, this is the reason, this is the explanation for the hyperosmolar hyperglycemic state. And then one more term is that is a hyperosmolar non-ketoic coma. So hyperosmolar, again the same thing, excess amount of, or there will be a high level of solute level in the solvent, and then non-ketoic coma. So just revise your DKA. In DKA we told there is a three entity. First one is hyperglycemia, ketone bodies, and then metabolic acidosis. Here there will be a no ketone trace. So if you check the check the your blood or urine level, means there you can't find any ketone bodies. In some rather time, you may get some amount of ketones, but not in a very huge manner, in a not very higher level. There will be a mild amount of acetone or ketone bodies we can trace, but not like in a DKA. There in DKA you can find a large amount of acetones or ketones, but here there will be a minimal amount of ketones will be there. Sometimes there won't be any ketone bodies. So and then one more thing, in DKA and then HHS, in DKA we told metabolic acidosis is a differentiating factor between your DKA and HHS. In HHS there won't be any metabolic metabolic acidosis. Okay, so this is the way you have to remember the DKA and then HHS. Mainly HHS will occur in the type 2 diabetic mellitus, whereas in our DKA we told that will mainly occur in the type 1 diabetic mellitus. So type 2 in the sense that is a relative insulin deficiency. So there will be a some amount of insulin secretion is there, but there might be a problem in the like insulin receptor related. That is why we told the name like a insulin resistance. Okay, mainly HHS will occur in the insulin resistance case or in a type 2 diabetic mellitus. So again this is the same thing. This is also same thing that we told regarding the HHS means what, and then it will occur in the type 2 diabetic mellitus without an acidosis, and then serum glucose level will be 400 to 1800 mg per deciliter. So causes for DK and then HHS, there is the same thing only. So there it's the in DK itself we divide the group into those who are under the insulin therapy, those who are not in the insulin therapy. And under the insulin therapy we told though there is an insufficient insulin dose or incompliance non-compliance state, or the person may skip the dosage, insulin dosage. So that is the things comes under the those who are under the insulin therapy. So without, so those who are outside the insulin therapy, so not taking insulin therapy means that the group of people, there might be reason for the emotional distress, or there is a problem, the person have a infection, infarction. So those are the things will comes under the non-insulin therapy peoples. So pathophysiology also same. So what we explain in the DKA, so the same concept only here will come. But in type here in HHS, what is the difference means, here you have a some amount of insulin, okay, right? Here you have a some amount of insulin, that is why we called relative insulin deficiency. Because of that insulin will fight back with the metabolic acidosis, means it is that insulin is enough to prevent the metabolic acidosis, but there is not up to the level of for transportation. Means here you have a some amount of insulin that will taken part, that will means that will prevent the metabolic acidosis, but it is not up to the level to transport the glucose from intravascular to the intracellular region. So that is the thing will happen in the your HHS. But in DKA the concept is totally different. There won't be any insulin. Because of that insulin you have an increased amount of glucose, there won't be any transportation. So the cell will ask help to the brain, and then the brain will activate the compensatory mechanism, thereby lipolysis, gluconeogenesis will occur. Because of that compensatory mechanism, there will be a formation of metabolic acidosis and then ketone bodies. Again there will be a hyperglycemic state. Because of the hyperglycemia you will lead to it leads to the secondary dehydration. So the all things will happen in the DKA. But here in HHS the concept is different. Here you have a some amount of insulin that is enough to prevent the metabolic acidosis, but not up to the level for the transportation. So this is the thing will happen in the HHS. Okay, so signs and symptoms, again this is the same thing. So because of that hyperosmolarity, and then because of that the hyperosmolarity induced dehydration, the person will have a hypotension, and then dehydration related assessments. You can see the oral mucosa, weak pulse pressure, tachycardia, hypotension, and then sometimes tachypnea will be there, and then decreased GCS, delirium, all the things will comes under the hyperglycemia. Those are the signs and then symptoms we will get in the HHS. So mainly in DKA, what is the differentiating factor? Because of metabolic acidosis, there you can see the Kussmaul's breathing pattern. So but in HHS that won't, we can't see any Kussmaul's breathing pattern. So diagnosis also in pre-hospital, the same thing, assessment point, dehydration related assessment point, glucose related things we have to carry out. In hospital, mainly we'll check the serum osmolarity level. So that is the one thing we have to check. So normal osmolarity, it will be like 275 to 295 milliosmoles per kg. But here the osmolarity level will be in a higher state, more than 295 you can identify. Urea creatinine level will be in a higher state because of the dehydration. Serum electrolyte also, sodium depletion will be there, potassium depletion will be there. ECG you can rule out for the hyperkalemia or hypokalemia, and then you have to work up for the what is the reason for the HHS. So you have to work out for the infection related causes. So assessment also same thing. Finally management part. So here what are the things we have to remember means, again the same triad only. So you have to manage the hyperglycemia, and then you have to manage the dehydration, you have to take on all the supportive measures. Okay, so first dehydration first. So both in DK HHS, your ideal first goal is you have to give the fluids. So you have to address the dehydration, that is the your first goal. So in dehydration here also we are going to administer the before that in DKA we told there will be approximately 6 liter of fluid loss will be there, right? In HHS double the time from the DKA means there will be approximately 10 to 12 liters of fluid deficit will be there in the case of DKA. So here you have to first 2 hours you have to aim for the 1 to 2 liters, exactly 2 liters we have to aim for the first 2 hours. means 1 liter per hour you have to aim, and then following subsequent hours 1 liter 1 liter, likewise you have to aim for the 3 to 4 hours you have to aim. Then the total fluids deficit means the 10 to 12 liters you have to correct over the 24 hours. Okay, you should not give with a rapid thrust, you should not give, we have to correct within a 24 hours, you have to correct the slowly, you have to correct the 10 to 12 hours, sorry 10 to 12 liters. But initially you have to give the 1 to 1 liter per hour for some 3 to 4 hours you have to aim for the 1 liter for first to 4 hours. Then you have to remaining fluids means remaining 6 means if you are taking 10 liters of fluid loss means, so first 4 hours we will give the 4 liters means that remaining 6 liters you have to aim for the remaining 20 hours. Okay, likewise you have to divide and then you have to partially or you have to slowly reinfuse the patient. And then that is the first management. Second management for hyperglycemia, this is also I explained in the DKA. So here we are going to administer the exogenous insulin in the form of infusion. So infusion wise, so here in our institution we will follow the 40-40 rule or 40-40 protocol. So the way is we will take 1 ml of human atrapid, short acting human atrapid. So that is your 1 unit in the sense that is 1 ml in the sense that is 40 units. So we will add this 1 ml into the 39 ml of NS. So the whole thing it will come 40 ml quantity. So the 40 ml again 40 units in 40 ml. So each ml contains 1 unit. So that is the way that initial starting dose we will start up with a 0.1 unit per kg. That is why you have to start and then you have to follow your, here in our institution we are following Delta protocol, but based on each your institution you may have a separate protocol you can follow, or up to you have to aim blood glucose level more than 250 milligram per deciliter. So if the glucose level less than 250 or based on Delta protocol, if it is less than 200 means simultaneously you have to administer the your dextrose solution or dextrose NS you have to administer. One hand you have to administer dextrose NS, on the other hand you can continue your infusion. Okay, but in the case of if it is getting less than 150 means you have to stop for the half an hour you have to stop for the infusion, then again after half an hour you have to re-evaluate the glucose level. Still if it is in a higher state you can restart the insulin infusion. And then electrolyte also, first you have to treat the fluid deficit, then you have to concentrate on the electrolytes like potassium, then you have to concentrate about the glucose level. So these are the complication: arterial thrombosis, stroke, renal failure, heart failure, MODA, cerebral edema, sepsis can occur. And then finally, so this is the two differentiation between the hyperglycemia and then HHS. So how we can differentiate? So for food intake wise, both DK and then HHS will be in excessive state. For that insulin dosage wise, both cases insufficient insulin will be there. That is why it's causing the DK and then HHS. Onset of both condition, but DKA means it will be take some hours to days. So very immediately it will develop compared to an HHS. In HHS it have a gradual development. It will take days to weeks. Skin wise, because of dehydration, both condition you will have a warm and then dry skin. And then infection wise, it's a infection is a most common cause for the DKA, but usually it can occur in the HHS also. And then thirst wise, intense will be there in DKA because of that hyperosmolarity. In HHS there will be a very intense thirst will be there. Hunger wise, both cases excessive hunger, there is a feature of your diabetic, right? Hyper means polyphagia, polyuria, polytipsia. And then vomiting, both condition like it is very common in the DKA because of the acidosis. It's uncommon in the HHS cases. Breathing part wise, because of that metabolic acidosis, you will get a Kussmaul's breathing pattern in the DKA, but it won't occur in the HHS cases. Order of breath, because of the ketone bodies, in your DKA you will get a sweety fruity odor smell, but in HHS it won't occur. And then blood pressure wise, both cases you will get a hypotension. Pulse wise, both cases again you will get a tachycardia. Level of consciousness, again it will vary from the fluid deficits. So if the person have a too much of too much of fluid loss means it can range from the mentation to the coma also. Urine sugar wise, both condition urine sugar will be there, trace will be there. Urine acidone, ketone bodies in DKA it will be there, but in the case of high HHS it won't be there. Blood glucose level again in DKA it will be more than 250 milligram per deciliter, but in HHS it will be more than 600 milligram per deciliter. Response to the treatment, again your DK and then HHS, gradually it will subside within a 2 to 3 days. So in DK itself I explained, like first that ketone bodies will disappear and then your metabolic acidosis will correct, then your hyperglycemia means glucose level come to the normal range. So the same thing only will happen in the HHS. So first here the osmolarity will correct, and then you will get a glucose also will come into the normal range. So this is the way you have to approach the DK and then HH cases. And then one more doubts we will create when we have to stop your insulin infusion, both in DK and then HHS. In the concept of DKA, if the person able to take orally and then resolving of all symptoms, like the triad we told, right, ketone bodies should disappear and then dehydration should address. So if those things are present, okay, settled means, then you can think about the like a stoppage of insulin protocol, means at the stoppage of insulin infusion you can shift the person from the infusion to the subcutaneous. Means first thing I told, the person able to take orally, and then second thing, there is a disappearance of ketone bodies and then resolving of metabolic acidosis is there, means you can straight away shift the person from the infusion to the subcutaneous insulin. In HHS cases also, the osmolarity level means your osmolarity level is a key factor that should get normal. Then you can think about the sugars also in a controllable manner, means you can means sugars not a key factor, osmolarity level is a key factor that should comes in the normal range. Then you can think about the infusion to the your subcutaneous insulin. Okay, so this is regarding the HSS and then diabetic emergency. So do your best. Shalom.